All right, everyone, we're going to go ahead and get started. Again, thank you everyone who tuned in. We're just going to go ahead and as people trickle in, we're going to go ahead and get started. So again, thank you all for coming and welcome to the first webinar of our virtual health winter health education series. This is the first webinar of about 8 that will be happening every Tuesday. Yeah. Just wanted to know that if you guys have any questions throughout the presentation, make sure to use the Q&A function, and then at the end of the presentation, we'll be answering those questions through our expert. Again, my name is Jorge Agustin, and I'm a community organizer with Increase the Peace and La Casa Norte. And just wanted to tell you a little bit about a quick introduction of the organizations. So I work with the Community Assistance Program in partnership with Increase the Peace and La Casa Norte, where we advocate for public health resources in the Southwest Side neighborhoods of Chicago, where we hire our youth through our Public Health Ambassador Program. And our youth leaders undergo leadership development trainings and workshops so that they're prepared to extend resources through our communities. To give you guys a little history on how our organizations were founded, Increase the Peace was founded in October of 2016 in the Back of the Yards community. And this really started over an overnight campout as a response to a teenage girl whose life was claimed in the Back of the Yards neighborhood. And then following the next couple of years, we were able to activate in 6 different neighborhoods and create safe spaces for residents, for youth in the community, and to overall bring resources to those communities. And now we operate in 6 of the following communities, which include Back of the Yards, Gage Park, Brighton Park, Chicago Lawn, Little Village, and Pilsen. And ultimately, our mission is to promote peace through leadership development, community organizing, and advocating for solutions to tackle root causes of violence. La Casa Norte was founded 20 years ago as an organization providing services and programming for young men migrating from South America facing homelessness. And for the last 2 decades, La Casa Norte has expanded its programs and services to help families and unaccompanied youth facing homelessness, food insecurity, and other public health services that they might need throughout Chicago. Now, I do want to introduce our expert and speaker for today's session, which we're focusing on what to expect during our annual visit to the doctors. So. And then to give everyone just a brief background on our presenter today, Megan Gonzalez D is a second-year family medicine resident at Swedish Hospital. She graduated from St. George's University of London at University of Nicosia Medical School in Cyprus, and did her undergrad degree at University of California, Irvine in Biological Sciences. She went into undergrad university knowing she wanted to pursue medicine and started out volunteering in programs, translating in medical Spanish for medical students and patients, as well as traveling to Tijuana, Mexico to provide medical care to the underserved communities there. Before she started residency, she did a 1-month internship in a clinic in Peru, providing school physicals and obstetric care to the surrounding communities of Cusco. Going abroad for medical school made her appreciate the diversity of the Latinx community in the US, and she was eager to come back to the States to practice in areas such as Chicago, where there is a big need for Spanish-speaking and Latinx physicians. Being at Swedish Hospital and working for the federally qualified health center, Erie has allowed her the opportunity to have access to various resources and be able to provide them to her undocumented and uninsured patients, Upon graduation, she hopes to keep working for an FQHC to continue serving these communities while also taking a special interest in women's and children's health, LGBTQ plus, and HIV medicine. And without further ado, I would like to pass it to our expert and speaker today, Megan.
Hi, everyone. Thank you, Jorge, for that really lovely introduction. I'm excited to be talking about one of my biggest passions as a family medicine physician. So we can get started. Today, I'll be talking about annual wellness exams, which is something that as family medicine physicians, we frequent. Awesome. Yes. So as you know, I work at Swedish, which is the hospital on like the north side of Chicago, and then the federally qualified health center that we are connected to is called Erie. Okay, so first off, I'll start off by talking about what an annual exam is. So basically, it is a preventative visit. It's usually done once a year, and it can be with your physician or another primary care provider, so a nurse practitioner or a physician assistant. And what we do is we screen for common diseases and mental health. My biggest passion is preventative medicine because I believe that if we, follow up every year with our patients, we can prevent them from going into the hospital. I think oftentimes when patients end up in the hospital, it's usually because from complications of their diseases that have gotten a little bit out of control or that haven't been diagnosed yet. So the overall picture, the idea is to diagnose it and identify it before it gets severe, before it gets to that really severe range and they end up in the hospital. So screening can include, taking your vitals, that can screen for high blood pressure and obesity by taking your blood pressure and trending it and your weight. We screen for lots of common cancers, alcohol and drug use, as well as depression and anxiety. And at certain federally qualified health centers, we can also ask questions and assess for food insecurity. And for our patients that suffer from that, we can connect them with resources. And it's also a good time to check in with your doctor about current questions or concerns that you might have too. So it's just like a check-in that you do once a year. Okay. So why is it important? Kind of like what I was talking about, screening tests are used when we look for a disease when someone does not have the symptoms. So the idea is to prevent, right? To prevent people from developing symptoms, let's say, of like their cancer. Because a lot of times once people are symptomatic is sometimes, unfortunately, when it's a little bit too late or when their disease process has advanced so far that medication can only do so much in interventions. So the idea is that we do it every year to try to identify early. When a person has symptoms, diagnostic tests are used to find out the cause of their symptoms. So ideally, if somebody, for instance, is coming with shortness of breath to a clinic, then sometimes it might be early, like let's say it'd be early on, like heart failure versus them showing up to the hospital. Then at that point, sometimes it's been a little bit far too advanced. So the idea is that we catch everything early on, specifically for cancer too, since as you can see, cancer is the second leading cause of death in the US. So 1 in every 4 deaths is due to cancer, unfortunately. So prevention is big here. And then ideally before we can actually identify it and then later on do treatment. Okay, so be prepared. One of the things that you can do to be prepared is ask your relatives about specifically like parents or siblings, any histories of cancers, any diabetes, any autoimmune disease like lupus, rheumatoid arthritis. Those would be some really common autoimmune diseases. Also cardiac diseases. Some that we really often screen for are if you've ever had a family member that suddenly died, while they were young for like an unexplained reason due to like their heart stopping. If you have family members that have had heart attacks really early on in their life. And usually what we like to see, or what's more relevant, I guess, would be if it happened in a first degree relative. So it'd be either like a parent or a sibling. It's really, really useful if you bring all of your medical records, especially if you're transferring from clinics, or if you were recently seen in the hospital. That's a lot of key information that can really give us an idea as to what treatments and diseases patients have, what medications they're taking as well too. And if you have high blood pressure or have a glucometer at home and you take your sugar, it's really important to write those down and then bring them with you to your visit, because taking your blood pressure one time in the clinic is really great, but what's even better is having more like objective evidence. So like to me, if you have a high blood pressure reading in the clinic, it might mean you could be a little bit nervous, which happens a lot in patients. But what gives me a better idea as to whether I should start you on a medication or whether we should change some of your medications is if your blood pressure, for instance, is persistently high at home. So that's why it's really good for you to take your blood pressure readings at home and then bring those to us, because a lot of times patients' blood pressure readings are normal at home and then they just get really nervous and then their pressure is high in the clinic. So we wouldn't want to change medications based off of just one high reading in the clinic. Always bring your medications and your supplements with you to every visit. It just really helps us see what medications you're actually taking. I've had patients that brought their medicine and they were taking two of the same one. So we can really regulate that too to see, because sometimes you don't know, and sometimes people don't really have the time to explain to patients what exactly every medicine is for. So I always love for my patients to bring the medication so I can go through with them, write down on the bottles, okay, this one you take in the morning, this one you take at night. So it's really important that you bring your medications and any vitamins too, because some vitamins and supplements can actually interact with some medications and some patients don't know that. So it's really important, always bring them with you. And then also, I like when patients write down in like their notes section of their phone, like just any questions that they may have. It's also really useful because it helps us go through like a structure. Usually I like to limit it to maybe 2 items per visit. I would love to go through, much more extensive list, but unfortunately we usually only have like a limited amount of time, like 15 to 30 minutes per visit. So what I usually tell my patients is to prioritize for this visit the 2 most important things that you want to address right now. And then at future visits, we can go through the rest of the list and address some of the other things. Okay, so what to expect during your annual physical. So the physical side, obviously we ask questions to do like screening, but then we also do like physical exam. So we do your height and your weight, and then and that's especially important in children to make sure that they're growing appropriately on their curve, like their growth curve. We compare your BMI, see if it's going up, if it's going down. So that's specifically important in children. If it's going down, like why are they losing weight? Or if it's continuously to go up, like abnormally, so that we can regulate maybe with like diet and exercise, like unhealthy eating habits. And obviously, like I said, we check your blood pressure, your temperature, and your heart rate. If your heart rate is really, really high, it can lead to some like cardiac diseases later on. So we like to make sure that it's a normal range. And again, if your blood pressure is elevated as well, it can cause a lot of issues for patients too. So it's important to identify that at the visits so that we can start medication or lifestyle changes. We always go through your medical and your family history in case anything has changed, and then a surgical history review. So if you've ever had intra-abdominal surgeries, C-sections would count as that. If they've been elective, meaning that, you chose to have the surgery, that it wasn't necessarily an emergency. Like gallbladder removal would be sometimes considered an elective surgery, and any emergent surgeries that you've had. Just because sometimes if you've had really big surgeries where they opened up like your abdomen, it can put you at higher risks of getting complications later on, like small bowel obstruction. So it's good for us to know that information. And then physical exams that we do, we'll usually do a neck exam to make sure your thyroid is like normal size, abdominal exam, a neurological exam for some patients, maybe if they're presenting with like, headaches or dizziness. And then we'll listen to the heart and the lungs. For women who are 25 years and up, we usually do breast exams to feel for any type of lumps. And then in children, we usually assess physical development. So usually to assess like puberty, that it's appropriate and that it's not too advanced for their age. Okay, so risk factor assessment. So usually we ask about smoking, drinking, recreational drugs, sexual activity, and recent travel. So it's really important that you be honest with your physician, no judgment, everything is confidential between you and your provider. So, and the reason is so that we can really provide you with the best care that, that we can give you. For instance, if you have a history of smoking, we can do screening for abdominal aortic aneurysm, which is basically a really big blood vessel in your abdomen. Sometimes it can get a little bit weak and it can like bulge out, and that can cause a lot of issues. And then if you've ever had like a 20-pack year of smoking, or if you currently smoke, or have quit in the past 15 years, then we do annual CT scans of your lungs to screen for cancer, because patients who have tobacco history are at increased risk of having cancer. So we want to prevent that and try to identify that. And then obviously if, patients are drinking excessively or are diagnosed with alcohol use disorder and want to stop, we can connect them with behavioral health or medications. And then for recreational drug use as well, it's important, that we educate you about the different types of effects on the body that can have, and assist with cessation if the patient wants to do so. Okay, so cancer screening in females or sex assigned at birth females, because not everyone that was born as female can identify as female. So people who have a uterus and a cervix. So from 21, you can start drinking. I tell my patients, but you also time forget your pap smear. So pap smears are basically, so I put a picture there of like the cervix. So normal, the cervix on the left, as you can see, there's no like abnormal cell growth. And on the right, there's a little bit more like dysregulated cell growth. And so it's important that we check that every 3 to 5 years, depending on your age and depending whether you've been HPV positive. HPV is a virus that lives in the cervical cells, and it can cause an increased risk of cancer. So now we have a really great vaccine for that. I really recommend all children to be vaccinated against it. But for some patients, including myself, who didn't have the opportunity to be vaccinated against that, we can screen for it with the pap smear. And then from 50 to 74 years old, depending on whether there's also a family history of breast cancer, if one of your family members were diagnosed with breast cancer or have like a genetic mutation, it's really important for us to know that, because then the screening would change. You would get it a little bit more younger and more frequently. But having a mammogram every 2 years is usually routine. And it can help us identify any type of masses or tumors that might be growing. And that way we can either resect them or do different types of like chemo or radiation. Okay, and then for males or sex assigned at birth males or people who have a prostate, so there is prostate cancer in a select patient population of 55 to 69. This is really based on like family history, race, ethnicity. So there are higher rates and mortality amongst African and the Caribbean population, and some maybe comorbid or coexisting medical conditions. We can screen for prostate cancer. This is really a conversation for you to have with your physician or provider, because if you have some of these risk factors, then maybe you would more likely benefit from cancer screening for prostate cancer. It's basically just a blood test. But if if not, because sometimes your prostate specific antigen can be elevated falsely. So a lot of times some patients can be subjugated to like invasive procedures and biopsies, and then they won't even have cancer, but then they have these really bad effects of erectile dysfunction and urinary incontinence. So again, it's recommended if you're like African or Caribbean, if you have a family history. Some patients just really, really want it, because they had a friend that had prostate cancer. Maybe they might be a little bit more worried, and we can totally do that. It's fine, just as long as patients are aware that sometimes it can lead to more procedures that are unnecessary in patients who don't actually have cancer, but their level was elevated for whatever reason. Okay. And so one of the really common ones too is colorectal cancer screening, and that is for everyone from age 50 to 75. And I believe in some clinics, in my clinic, we're actually just doing it starting at age 45. So this, what it does, so classically, we used to do it with a colonoscopy on everyone, but now there's a bunch of different methods, because I know not everybody, if you don't know what a colonoscopy is, it's basically a camera that is advanced through, the anus to the rectum up into like the colon. So it can be kind of scary for some patients, and obviously they're sedated, so they don't remember, but the whole idea of it, I know a lot of patients that are really averse to it. So now what we do is, specifically at my clinic, we do the FIT test. And what that is we give them like a little kit. They bring us a sample of their like poop basically, and then if it's positive for any blood, then they do a colonoscopy, because that might mean that they might have like a polyp, and that it might be bleeding for whatever reason. But if it's negative, then they can just repeat it the next year. And so a lot of patients are way more agreeable to that than having a colonoscopy. And then there's also the Cologuard, which is the same test, but that one's done every 3 years. So it checks for something other than the blood. So depending on insurance, depending on your clinic, and where you are, those are the various different methods. But the idea is that we do this so that we can find polyps, remove them before they become cancer, as you can see on like the little picture there. So cancer takes a very long time to develop. So that's why colonoscopies are usually done every 10 years. If for whatever reason they find some polyps that are looking a little suspicious, then you would do colonoscopies more frequently, like every 5 years. Okay. Then we have STI screening. So screening for HIV and hepatitis C with just a blood test. And then screening for chlamydia and gonorrhea. And so classically, most patients do have symptoms, but there are also a big population of patients that don't have symptoms, and they can be asymptomatic. So it's important that all patients who are sexually active and less than 24 years old get screened at least once a year with just either a urine or a swab. Because if patients have asymptomatic like chlamydia or gonorrhea, it can cause a pelvic inflammatory disease, which is basically the uterus gets like lots of inflammation that causes scarring. So later on, if patients are trying to get pregnant, it can actually cause a lot of issues like ectopic pregnancy or like lots of miscarriages. So it's important that we identify if patients have that, because we can actually treat it with antibiotics. And then anybody at increased risk over 25. So that would mean patients who aren't using barrier contraception, or patients or like sex workers. And then syphilis screening would be in high-risk populations as well. So patients who are having sex with multiple partners and aren't using barrier contraception, and probably sex workers as well. And then it's also really important to screen for mental health and intimate partner violence. So at our visits, usually we give certain like questionnaires. So you'll probably get like a paper and like you'll have to fill it out to see, for instance, like if you feel worried and if your thoughts keep you up at night. Those are some of the questions that like and how often that interferes with your day-to-day life. That's on the GAD-7. And then the PHQ-9 is like if you're having a low mood, and how often that like affects your life in terms of you not being able to like go out and do things or go about your life because your mood is so low. So those are some of the ways that we can identify patients that actually need like either behavioral health, so like counseling, or there's also medications that we can give. The best actually efficacy is counseling combined with medication. And then also we ask questions to screen for intimate partner violence because unfortunately that is pretty common, especially in the patient population at Erie and in a lot of the underserved communities. I identify that not all patients who are in maybe violent relationships want to leave, but it's important that we at least have a plan in case something happens. Okay, and then vaccines. So it's a good time to talk about vaccines, like the flu vaccine, which everyone should go get their flu and their COVID boosters. So the flu vaccine can cover for 4 different strains. We usually start giving it around August and September. The boosters, so the COVID boosters for children, now we're doing 3 doses for 6 months to 4 years for Pfizer, 4 doses if it is Moderna, and then from 5 to 11 years, it's 4 doses. It's basically 4 doses from 5 to like and up. So it's a good time to get your flu and vaccine boosters. And then shingles is a vaccine that we do for adults 50 years and up. Prevents shingles, and there's a really bad complication of post-herpetic neuralgia. And what that is basically where the blistering happens, patients get a lot of nerve pain and it's really, really uncomfortable. So it helps prevent those 2 things. And then obviously like the pneumonia vaccines for all children. And there's actually pneumonia vaccines for patients that are 65 and older because they usually tend to have more severe symptoms. Okay. And so, because I'm family medicine, so we do children and adults. So at the pediatric visits that we have, it's really important early on in the first 2 weeks of life, we do lots of weight checks. And I know for some parents, especially like new parents, it might seem a little bit tedious to be coming back and forth to the clinic like every 2 to 3 days. But really why it's so important to make sure that the baby is gaining good weight is because if they're not, it could signify like underlying maybe like cardiac disease, or like a disease or a metabolic disease. So it's important that we identify that early. And then in the first 2 years of life, as you can see in like the picture, we have pretty common visits like every 2 months, 6 months, even like at the 12-month visit. And that what really like the importance of that is making sure, you know, they have the correct amount of words, making sure that their motor skills are developed, that they're behaving appropriately around others, because early intervention has shown that we can really, for instance, in patients who have autism, the earlier that we get them into like seeing their behavioral therapist, the occupational therapist, the better outcomes we have later on with them kind of like curbing some of the behaviors that they have learned earlier. That's it. And then we do blood tests too. So we check for hemoglobin, which basically tells us if a patient has anemia. And it's important. I know in Chicago, most houses and buildings were built before 1978. So classically, a lot of the kids, if they're like putting like paint chips or like touching the walls with the paint's really old and it has lead in it. So it's important to do some blood work to screen for that too. And then at 11 years old, we always check for cholesterol. And then if children, a lot of our children sometimes are moving from different countries or traveling a lot. So some of them have missed their vaccines. So it's important that we identify that so that we can catch up on them. And that way they can start school on time as well. And then we do vision and hearing to make sure all kids that need glasses get them, or if there's a concern for hearing loss in some infants, that we get them to the specialists that are appropriate. That way they can get like their hearing aids and stuff. And then always you screen for depression and anxiety in teens, and then sexual abuse or neglect in the home. So common blood work that can be done at an annual visit. And I put in the, like for instance, the CBC and the BMP, I put that in just so that, because sometimes when we give the after visit summaries, it has a list of all the blood work that's done and patients don't really know what that means. So now you'll know, like a CBC means that we basically took a panel and looked at your white blood cells that can tell us for like signs of infections, your red blood cells. We looked at your hemoglobin, because that can check for anemia. Sometimes when patients complain of lots of fatigue, and especially women too who are at a higher risk because they have because they menstruate, we do CBCs to make sure that they're not anemic. And then there's the BMP and the CMP. So these are the metabolic panels. So there's the basic one. So that looks at electrolytes and it looks at your kidney function, which is really important for patients who have diabetes. And then there's the CMP, which is the comprehensive. And the difference between those two is that the comprehensive one, the CMP, also looks at the liver function. So me classically, and my patients who are like maybe obese or that have diabetes, I will usually do a CMP for them because a lot of them probably have like fatty liver disease as well. And that's one of the ways that we can identify that, is by doing that blood work. And then usually we'll refer to get an ultrasound, and on ultrasound we can see that they have kind of like, as you can see, the little, some patients that are a little bit more like overweight have more fat deposits on their liver. And if it's caught early on and patients change their diet and lose weight, then there's lesser risk of them getting like end-stage liver disease and cirrhosis, which can be very, very detrimental for patients. And then vitamin D. So most people in Chicago are vitamin D deficient. We don't have a lot of sun in the winter, so that's usually our main source of vitamin D. I have a lot of patients that come in and they have like a lot of vague symptoms, like they're tired, they kind of have like a low mood. So I always screen for vitamin D. It's just a blood test that's basically done, and it's the easiest like fix basically, because you can either start a supplement or just add more to your food. So usually you can like you can even buy vitamin D like over the counter. And then based on how low your levels are is like how much you should take. So it's good to actually get the blood test done so that we can recommend, based on how low it is, how much of the supplement you should take and how often. And then a lipid panel as well. So ideally it is done when you're fasting. So I like to tell my patients, usually if you know you're gonna schedule your wellness visit, try to do it early in the morning. That way, you know, you're fasting and you can go get your lipid panel done too. That would check the level of your cholesterol and your triglycerides. Your triglycerides are something in your blood that if they're really, really high, they can cause things like pancreatitis. Sometimes if you're not fasting, your triglycerides can be a little bit elevated. So it's best if you're fasting, that way we know, okay, they actually are elevated. It's not because this patient ate literally right before their visit. And then the hemoglobin A1C. So basically what this measures is, as you can see in that little picture, so sugar gets stuck to the red blood cells, and the red blood cells live for 3 months essentially. So we can take some blood and we can basically, look at how much sugar is like stuck to the red blood cell over the past 3 months, and that gives us an idea as like how like an average level of how much glucose was in or how much sugar was in your blood. And so, and it's really good because it tells us over like a 3-month like period or history. So if patients say, yeah, I've been taking my medication, I've been doing really good, but then, you know, their A1C might show otherwise, then it just really gives us a really good idea so that we can also help patients too get better regulated and under control. So 5.7 to 6.4% is prediabetes, and then diabetes is diagnosed once it's 6.5% and above. And it's really, like I said, important for diabetics. Diabetics, we usually want to get it below 7. And it's just like a number that patients can have in their mind, and like it motivates them to get it lower. So it's nice to trend it more often for diabetics, once a year for patients who are pre-diabetes. Okay, so that's my presentation. Thank you guys for listening. And if you have any questions, I would be more than happy to answer them.
Awesome. Thank you so much, Dr. Megan, again. And again, for anybody interested in asking Dr. Gonzalez here any questions, feel free to drop them in the Q&A function, and then we can go ahead and make sure that they're answered. So give you guys a minute or two to drop your questions, and then we'll go ahead and jump in.
And just to note, the questions are anonymous. We don't know who sent them. So if you want to put them in the Q&A chat, if there's any sort of, you know, dire questions that you're a little bit nervous to ask, we can answer it. So we actually have our first question. So Dr. Gonzalez, what can be helpful to get the cholesterol down?
Yeah, so exercise is really important. And I know when people think of exercise, they probably think, oh, I have to go to a gym, or I have to go out and run, or I have to lift weights. But it's really just like at least 20 minutes a day of like some type of like movement or activity. That's one of the main ways to weight loss can help as well. And then cutting out fat, so like non-fat things, like non-fat what's it called, yogurts, milk, that can also aid in getting cholesterol down. And some people do like supplements, like the omega-3s too can help, and like the fish oils. But yeah.
Awesome. Thank you so much, Megan. And then we have another question in our Q&A section. Can you explain a little more of how glucose is measured in the blood and the ranges that classify a normal, pre-diabetic, and a diabetic? And how do you read the details in our lab results?
Yeah. So usually a blood sugar less than like 120 is normal, but it's fasting. So it depends, right? It depends when the blood sugar is taken. So what we do is like we'll take like a prick of blood, or they'll take actual blood from your like your arm or the finger. And it's important to know, for instance, how if you ate, like how long ago did you eat? Because like there's the postprandial, like the 2 hours, that level, and then there's the fasting. So fasting your blood sugar, if you haven't eaten anything, it really should only be like around the 100s range. Like the highest would be like 120. If it's after you've eaten, really should only be like around like 180 to like 200, especially depending on how like long it's been since you've eaten. But usually like we give like a 2 hour range for diabetics, or just like people in general. That's usually how high it should be. And then when we do your blood work, what we look at is So anytime, let's say I have a patient that comes in with like specific questions or like concern, sometimes I'll do like a broad kind of range. Like fatigue is a really common like complaint that patients come in. So I'll do like I'll check for anemia, so I'll do the CBC. I'll check for like vitamin D levels, so I'll do that. And then sometimes you can do like a thyroid level. So when we get all of that information, we look for anything that might be like abnormal. So if the hemoglobin is low, then that would indicate anemia. And then, okay, we have our diagnosis. If like your TSH or your thyroid level is like abnormal, so your TSH, if it's like high, then that could indicate that maybe you have hypothyroidism. So that could be like a cause for like one of the symptoms or how you're feeling. So really, when we do the blood work, sometimes we do it very broad. That way we can, just really get a very comprehensive like look as to what exactly is going on with the patient, and any abnormal levels really tell us what's going on. I hope I answered that.
Thank you so much, Doctor. And we have another question. Has COVID affected the specifics of what you should look for or ask about during our annual visits?
That's a good question. I guess mm, not. I mean, maybe some people don't look in like the throat anymore for like some like visits, but I think the way that we have now structured, for instance, our clinic is, and I know that some clinics weren't taking kids who are sick actively, so I know that can really affect, because when patients are sick, obviously they need to be seen by a doctor to get the proper treatment. So ways that we have combated that are telehealth visits, which are useful because sometimes depending on what the symptoms are, that's we can diagnose over like the phone or over like Zoom. Another one that is we have like urgent care spots now, so where we only see patients who are coming in with like acute like what is presumed to be like a cold or like COVID or like flu, viral or bacterial infections. So that's one of the ways that we've tried to like mitigate that. I think as time has passed since like the initial pandemic, we've gotten more better at trying to navigate that. I know initially some clinics weren't seeing any people or kids that were sick, but now we're really opening up to identify that, these people do need to be seen. And so whether it's telehealth or whether it's, a specific urgent care slots that we can actually provide that. Obviously, every clinic is different. But that's just one of the ways that my clinic has kind of come up with as like a solution to COVID.
Great, thank you so much. Then going on to our next question. Someone asked, is prediabetes reversible? If so, what are some recommendations?
Yes, prediabetes is reversible. Diabetes, unfortunately, is not like once you have a diagnosis, even if your blood sugar is controlled, it doesn't mean that unfortunately you don't have it anymore. So that's why when patients are in the pre-diabetes range, so when their A1C, which is that blood level that basically looks at the percentage of sugar that has been in the blood for the past 3 months. So when it's less 6.4 or less, we can still do like lifestyle changes. So that meaning like weight loss is one that's really important. Exercise is another one. Anytime that you exercise, it shoves like all of the free range sugar from in your blood to go into your organs. So what diabetes is basically there's a lot of sugar just free floating in your blood. And the issue with that is it can accumulate in like small vessels of like your fingers, your eyes, your kidneys, your feet, and it causes damage. And so it damages the nerves, it damages the blood vessels. And over a long period of time, even though patients probably feel fine in the moment, that consistent damage over time is what can cause for instance, like heart attacks and strokes and kidney failure. And then when patients don't have that sensation of feeling in their feet, and then they get injuries that get infected, then they need amputations. All to say that we can prevent that when patients are in the pre-diabetic range through weight loss, changing. I really like, it's called Plate Planner. It's like an online source, and it basically shows you, I like printing this out for my patients. It's not that you have to cut out like carbohydrates completely. And what carbohydrates are is like bread, white rice, pastas, what else? Like tortillas, stuff like that. You don't have to cut it out completely. What I like to say is just reduce the amount that you eat of that. Like I would say like half your portions of that, and then supplement it with like vegetables, and like greens and fruits and stuff, or nuts as well too. So cutting down on your carbs and supplementing with it, so you don't have to starve yourself, just kind of reduce those portions. And then weight loss, exercise, and basically changing how you eat. And then there's also medication that we can give. One of the more common ones is called metformin, that we can give pre-diabetic patients. And the nice thing is, if you're pre-diabetic, it doesn't mean that you have to be on this medication for forever. It's basically to help you regulate your diet and your sugar levels. Sorry, not your diet, your weight and your sugar levels, because you can actually lose a little bit of weight while you're on that medication. And then ideally you're doing so good with like your exercise and what you're eating that you can just be off the medication. And then your sugar levels also like regulated without it.
Great. Thank you so much, Megan. We have two more questions. One more is, what is the difference between both diabetes?
Oh, type 1 and type 2?
Yes.
Yeah, that's a good question. Yeah. So type 2 diabetes classically happens a little bit later on in life. And what that is, so we have this in our bodies, we have insulin. And what insulin does, it like grabs onto the glucose and it brings it inside our cells, where it's supposed to be. Because inside the cell, it's like nutrition for the cell. But if we're eating so much sugar, and sugar doesn't even mean just like sweets, different things like carbohydrates, which are like breads, pastas, tortillas, that gets broken down into sugar as well. So if we're eating a lot of that stuff and there's a lot of free floating like sugar in our body, then the insulin kind of just gets overwhelmed and stops working, is what essentially I explained with patients. So then if our insulin is not working, then we end up having a lot of sugar that's just free floating in the blood, and it's not inside of the cell where it's supposed to be. And that's where it does the damage, because it's not supposed to be in your blood. It's not supposed to be like accumulating in like your small blood vessels. So that can be fixed and changed with medication, weight loss, and diet modification. And usually it's seen in patients that are a little bit older because it happens over time. So that's type 2 diabetes. Type 1 is usually an autoimmune, well, it is an autoimmune disease. So basically what happens is we have our pancreas that have different types of cells that make insulin. And so those cells don't work because their body is attacking those cells. And so it destroys them, and then they don't have insulin. And so then they're not able to like normally, like their own body's not able to regulate their sugar. So then they have to inject insulin, or some patients have like a pump too that is constantly like ejecting insulin into their body to help the sugar go inside the cell. So one is basically their body is attacking their own source of insulin, and another one is their insulin doesn't work because it's just been overloaded by all of the sugar in the body. So that's why patients with type 1 diabetes, they can be younger, and then patients with type 2 diabetes, they can be older, because it takes time. And type 1 diabetes is usually just a dysfunction of their body hopefully that made sense.
Perfect. Thank you so much, Megan. And then just our final question, someone asked, how do you get over the fear of following up with your doctor, not wanting to hear bad news? For example, the last time I was at the doctor's, I was told that I had a high blood pressure and was pre-diabetic and never went back because I didn't have the mental capacity to handle it. Also, how do you ensure that you are not misdiagnosed?
Yeah. So I guess that can be really scary, right? I know sometimes it's associated with like every time I go to the doctor, they're gonna tell me I need to lose weight. They're gonna tell me like I need to do this and I need to do that. So I think it's a matter of just identifying that we we're not the bad guy. We're not doing that just so like we're doing it for your own good essentially because we want to help you. And I think it's also a matter of patients also realizing that this is going to help me in the long run. And like I know it's like uncomfortable to talk about these things, but like we have to talk about them because the person that ends up suffering is the patient, right? Because then they end up having, getting a stroke because their blood pressure is not regulated. And I think obviously there's going to be a baseline kind of like anxiety that I think comes with everything, but it's I think acknowledging the fact that you want to live a long and healthy life, or if you want to live to like see your grandkids or whatever your motivation is, to help you kind of get over that fear. And it takes a lot. And then also sometimes it might take, a provider or a physician that you feel comfortable with too. Like not we're human. We all have our own personalities and our quirks. So maybe if you didn't feel comfortable with that physician or with that provider, you're more than welcome to find a new one until you find someone that you can really connect with and be like, okay, I feel comfortable talking about them with these things and sharing these things. So it really goes both ways too. And sorry, what was the second part to the question?
Oh, and how to avoid getting misdiagnosed.
Yes. Okay. Yeah, that's right. So, always ask for your blood work and your labs. I always love giving it to my patients and explaining it to them. Like, so your pressure, let's say, was 150/80, and because the top number is 150, that means that you have high blood pressure because the upper limit is like 140. So always ask them to like give you the papers, let's say, and then after visit summary. I love giving after visit summaries and just like literally circling like this is what your level is, and then ask them to show you your lab results too. I always show them on the computer, my patients, like I'm not making this up, this was your lab result and like this is what it means too. So don't be shy, because ultimately this is your body, right? And you want to make sure that you get the best care for yourself. So it takes a little bit more initiative, because a lot of times, I mean, unfortunately we're rushed, right? Physicians are rushed because we literally only get 15 minutes with patients, and it's so hard sometimes to address that. But I always like to take my time with patients to explain to them things, to show them things, but I realize that not everybody does that. So if ask for all of your blood tests. I like reading out the reads. Like if the patient has a chest x-ray, I'll like literally show it to them and I'll read it out to them, because it's important, it's their body. But like again, I know that not everybody does that because of time constraints or whatever, but I really really encourage you guys to ask and have your provider, your physician show you too. That way you can build that relationship, and eventually you'll gain more trust, who are like, okay, you know what, I trust what they're saying. They're not gonna do anything or prescribe me a medication that's harmful for me.
Awesome. Thank you so much, Megan. And I think that's all of the questions that we have time for. So right now we're gonna pull up on our screen just information about next week's series that will be taking place on the same link that we used today. I just saw that Priyanka also dropped it in the chat. And similarly to this week, 6 p.m. will be for the English portion of next week's webinar, and 7 p.m. will be for those who are interested in Spanish. And our presenter for next week will be Geraldine Luna, and she'll be focusing on senior care for seniors and senior care providers. Again, for both English and Spanish sessions, we'll be using the very same link that we used for today's session, and it'll be the same link for each following webinar session for this series. And if you have any questions that you would like to ask and you didn't get a chance to get them answered today, make sure to forward those questions to Priyanka. She has her email address down here. Thank you, Priyanka. And yeah, feel free to ask any questions you might didn't get a chance to ask or didn't get an answer to. And then just a brief informational slide over what the Southwest Organizing Project does. Here you can see some of the resources that SWAP provides. You can see they have Medicaid for immigrant adults, ages 42 and up, and for seniors 65 and up, and plenty of other resources that you yourself or maybe friends or family might find valuable. Also, just to register for the next series, here is also the link, the QR code. You can use that to go ahead and register for the next series. Yeah, and I believe that is all, unless Priyanka, you have anything else to add. Other than that, thank you so much. Oh, sorry, Priyanka, did you have anything else?
Yeah, I just wanted to say the Zoom registration link for next week and the rest of the 7 sessions is actually in the chat. And this QR code is for our Google form. Our public health ambassadors can reach out to you after if you have any specific questions or resources, such as the ones on this list. They're happy to reach out to you to provide things like Medicaid, how to enroll for SNAP benefits, et cetera, like citizenship, DACA, immigration. So if you need any help outside of what we talked about today, our PHAs can reach out to you later this week. So the link is in the chat, or you can use this QR code. I'll leave it up as we just are about to start the next session in Spanish. Thank you, everyone.
Awesome, and thank you again, Megan. Thank you so much for helping us host this session for our English portion. And thank you everyone who joined us this evening. We are going to go ahead and commence our Spanish portion. So thank you all again. And thank you again, Doctor, so much for your help.